Vincent, I can't find the bios. Wait, let me see where they are. Oh, found them, thank goodness. Good evening. Bienvenidos a todos y gracias por estar hoy con nosotros. Welcome and thank you all for taking time to be with us today. We are very excited to host 3 leading authorities in the field of monoclonal antibody therapy. They will be sharing their expertise on this milestone advancement in the treatment of COVID-19. Some basic housekeeping. Participants will be muted during the presentation to allow the panelists uninterrupted time. We very much look forward to your participation, and the panelists will be responding to your questions at the end of all the presentations. So please place them in the Q&A section at the bottom of your screen. If you miss anything, don't worry. We'll give you more information later on how these sessions are recorded. And we will be sharing links for the recording as well as for obtaining continuing educational credits. To start off, by now we all know that coronavirus has disproportionately affected Latinos. As of May 2021, based on data from the Kaiser Family Foundation, Latinos represent about 1 out of 5 persons living in the United States. Yet almost 1 out of 3 reported cases of COVID infection were among the Black and Latino residents of the US. COVID-19 associated hospitalizations are also higher among Latinos. As of May 2021, that is this month, based on data from the Kaiser Family Foundation, Latinos, as we said, are overrepresented in both cases and hospitalization. Vaccination rates as of May 25, which was yesterday, among residents that have received at least 1 dose of vaccine have also been below the national average for Latinos, with Latinos being vaccinated at an average rate of 14% compared to 62% among white residents. These numbers bring home the fact that even though we have effective and safe vaccines, many people, especially from historically marginalized groups like Latinos, will continue to be seriously ill. Making today's presentation on the science and equitable access to monoclonal therapy treatment crucial for our community and for all of us at large. I would like to start by presenting our first speaker, Dr. Jeffrey Bander. Dr. Bander received his medical degree from Harvard University and now serves as an associate professor of medicine at the Mount Sinai Hospital and School of Medicine. As well, he is a medical director for the network development in the Mount Sinai Hospital Network of New York. Dr. Bander is currently the chief of cardiology at Mount Sinai West. During the COVID-19 pandemic, Dr. Bander helped lead the health system's convalescent plasma program and coordinated large donor drives to assist in the production of hyperimmune globulin. He has helped operationalize monoclonal antibody infusion at Mount Sinai and has spearheaded patient awareness campaigns among local communities. Welcome, Dr. Bander. We're very anxious to hear your presentation.
Well, thank you for having me. It's great now to be talking about monoclonal antibodies when we're not in the heat of the pandemic in the country, but as you said, certainly large portions of the countries, especially in your communities, that still have it, and it's a really underutilized treatment. So I'm glad to give a little bit of background. Go to the first slide and discuss, the background, why we should use it, its efficacy, and I want to just stress some key points, and then move on to the other speakers. But we're here to talk about what monoclonal antibodies are, and essentially the FDA has 2 emergency use authorizations to give monoclonal antibodies to treat patients who are at high risk for developing severe COVID. We'll talk about what that means, but these are your patients, diabetics, older patients, or patients who would be of other risk factors, which we'll get to. And these are 2 products. These are antibodies against a spike protein, and now they're given in combinations. There's 2 products from Regeneron and Eli Lilly. We're going to talk about how they must be used in 10 days, and I'm going to spend some time speaking about the rationale for that, because I think that's one of the reasons it's not used enough, is that people aren't sick when they first get COVID. And by the time they're sick or they're really ill, it's too late to use it. So giving this early is going to be the main key message, and that this is a really safe and effective use. And it's for patients who are ambulatory and they're not on oxygen. And I think the most important key point I want to stress for everyone, this is the only therapy for patients who actually have COVID that has a 70% reduction in hospitalizations and ED visits. That's a 70% reduction. That's more effective than any of the other treatments that we have for patients with COVID. So why is it not being used? We'll get to that later in the talk. Let's go to the next slide. So what are monoclonal antibodies? So just review some basics. SARS-CoV-2, the virus that causes COVID, is made up of many proteins. The spike protein, which is this orange protein on the outside here, is the key. This is the protein that binds to human cells and allows infection to occur. Now, over time, 7 to 10 days, your body usually develops antibodies against all the proteins, but especially the spike proteins. And these are called neutralizing antibodies. They bind to the spike protein and don't allow the virus to enter the cells anymore. So that's what sort of stops the further spread in your body and allows your immune system to clear out the virus. Now, what I said is that this takes time. And if you go to the next slide, it's time that we don't have. So COVID is really divided into these 2 phases, stage 1, stage 2, and 3 stages. And it's this early infection stage where the virus is replicating. That's when patients have a fever, they're not feeling well. And then that stage where you see the patients in the hospital, they're intubated, they're on high doses of oxygen. Now, by the time you develop antibodies, 7 to 10 days, you may already be in this second stage. So it's really important is that we give antibody therapies early on. So we give it to patients who are at high risk in this first part of the disease when they may not have as many symptoms. So we can go back one slide. So what are monoclonal antibodies? Essentially, we're cheating the immune system. We're basically giving patients a head start. It takes 7 days to develop it. We've taken cells from patients who have recovered, made millions of copies of it, and producing lots of antibodies, and basically giving you a 7 to 8 head start. So we can go on to the next slides. Next slide. So as we said earlier, it's really important now we understand if we give the antibodies earlier, we can clear the virus earlier. And so that was the rationale why the government and industry went together and really went in the heat of the pandemic to study how these drugs work. So the first drug, which was one monoclonal antibody called bamlanivimab, Eli Lilly did a large study. This is good science. They took 465 patients. They randomized them to either receive an infusion of these antibodies, IV, or placebo. And you can look on the chart on the right, it might not look impressive, but this is a logarithmic scale. They started to see a trend in lowering of the amount of virus circulating in the patients. What was really interesting, even though numbers were low, they showed that the patients who received the bamlanivimab, only 4 out of 136 ended up progressing to require medical care, ED visits, hospitalizations, while 7 patients ended up who got placebo got sick. So this was really exciting, looking at a trend towards a real benefit. Next slide. Around the same time, Regeneron produced their own combination, 2 antibodies that all bind to the spike protein, 2 different ones, different areas. And they did, again, good science, randomized patients. They didn't know what they got. Half of these patients got placebo, half the patients got these antibodies. And again, so now they showed significant reduction in the amount of virus. But again, most importantly, the patients who received antibodies had a significant reduction in the amount of events. So again, small numbers, but we're looking at 50 to 70% reduction in patients using ED visits and hospitalizations. When they took these patients and they said, let's look at patients who are at high risk, what we're going to call EUA criteria patients, diabetics, patients over 65, obesity, they found a 9% versus 3% rate of hospital ED visits and hospitalizations. So a significant 70% reduction. So this is what sort of got everyone excited, and we went out to market, and Dave will tell you to get this into patients. Next slide. So as time went on, as we said, Regeneron has 2 antibodies. Eli Lilly added a second one. And why it's important, especially now that we have vaccines and everything else? Well, we're all hearing about variants. And in variants, the thing that we worry about the most is there's our mutations in the spike protein, and which changes, which allows the virus to enter and escape, we call escape antibodies. And so what we've shown is that with Eli Lilly and other drugs, when we combine 2 of them, we have a more effect. So 84% reduction when we use these 2 antibodies of Eli Lilly. Next slide. I'm not going to go over this slide, but this is just to show you that everyone's talking about the variants. But even though there's been data that shows as the virus changes, the spike protein changes, and some of these antibodies don't bind so well, when we use combination therapy, at least clinically, there seems to still be effect of these drugs. So even with the mutations, we're still giving it, but what's really important is we no longer give any of these antibodies solitary, they're given together, because if there's one mutation, then at least the other antibody will bind. So that allows us to continue to treat. Next slide. So just to review, I don't want to get really too academic, but what I think people don't realize is that how much science went to that. There was a lot of debates about looking at hydroxychloroquine and other treatments. But when you look at monoclonal antibodies, there's good double-blind, placebo-controlled trials showing a 70% reduction in hospitalizations and death. So both in the Regeneron and in the Eli Lilly, these are looking at symptomatic patients who are in their first 5 to 10 days of disease, who get treated, have this significant reduction in viral load and significant reduction in death and hospitalizations, if you look at the data directly. So very, very impressive data, very, very good use of the Medicaid, of this therapy. Next slide. So just to skip ahead, as the virus changes, there's more antibodies in the works, and we're looking at AbCellers making antibodies that bind to different parts of the spike protein, that even if the virus changes, these are areas that don't change much. So even if the virus changes, we're going to still have this therapy ahead of us that we can treat if it breaks out. Just helpful to know. Next slide. So what are the high-risk criteria? I know that Brian will go into more of the nuts and bolts of how you screen patients, but briefly, it was obese patients, patients with kidney disease, diabetes, anybody taking immunosuppressive disease over 65, or patients 55 and older that have cardiovascular disease, hypertension, or lung disease. Now, as the pandemic has sort of waned and we've learned more and more of the efficacy of it, the government's starting to change what the criteria are. And we know that obesity is a really big risk factor. So it used to be 35 and now it's 25. So basically it's opened it up a lot to patients who are just overweight and at risk are now eligible to receive this. What you have to understand is that when we first developed this treatment, it was felt that we wouldn't have enough to give everyone. And now as the virus numbers are down, we have enough. And so we'd like to get it into people who will benefit the most. So that's why it's changing. And I think most importantly relevant here, and I know that Dr. Captain Wong will talk about it, is that members of groups that are traditionally been undertreated or not have available treatments will be available for them as well, because they're higher risk for developing the disease. So this is again for adult patients. There's also criteria for children, but not really used that much. The most important thing is that they're not on oxygen. So as long as they meet any of these criteria and they're not on oxygen, you can administer this as an outpatient. Next slide. So we'll go over quickly. There's some data looking at this. Prevention is not as relevant anymore, as patients who are vaccinated. Essentially, this is giving a vaccine, a temporary vaccine by giving antibodies, but effective. Next slide. Next slide. So just to give real world data, when this first came out, the Mount Sinai Health System, we were one of the first to put up a large infusion center. And when we looked at our data, we have a pretty, very high comorbid population. We looked at our failures of the first, 200 some odd patients. We found that the majority of patients who progressed despite antibodies were patients either with with organ transplants or patients with rheumatological diseases. But in our patients that were our standard diabetics, obese patients, we showed similar data to the EUA, but our patients with metastatic disease or rheumatological disease still tended to progress on. Just an important fact to look at who's at the highest risk. Next slide. So why hasn't this been utilized? I think that it's really important that the providers haven't really been made aware of this. We've all been talking about vaccines the whole time, and that probably is actually more important. And this is sort of a secondary point, but especially now with preventive disease is important, but people were unaware of this. And it's the time for treatment. As I said, you got to get this in early before patients are sick, and then resources wise. And so I think now these problems are being solved by having conversations like this, but providers need to be aware and patients need to be aware to seek it out. And a lot of work is being done in this area. Next slide. We've just to mention what we've done and we're doing here is again, educating your communities, going through to patients, direct advertising in newspapers, media, and having talks like we're having tonight with providers. Next slide. And so we've worked with many groups. We've now probably given over 10 to 20,000 transfusions across the country of different groups. And I hope that you guys have learned a little bit about the background for this. I'll move on to the next speakers.
Okay, well, hello, everyone. Thank you again for the opportunity to speak tonight. My name is Captain David Wong. I'm a pediatrician. I'm Chief Medical Officer at the HHS Office of Minority Health. I was also deployed to the Federal Therapeutics Team, which is formerly known as Operation Warp Speed, for about 4 months while these monoclonal antibodies were being stood up. So I'm happy to share some of that experience with you today. Next slide. So just to kind of piggyback on Dr. Bander's talk, I thought I'd start kind of with the bird's eye view of treatment options for COVID over the past 15 months or so. And this schematic really looks at you going left to right. You're looking at no illness going into inpatients and then ICU admissions. And for the first part of the outbreak, the pandemic, really, we only had treatment options for folks that were inpatients. And in the right side, you'll see the yellow boxes at the top, which are antiviral therapies. So the first antiviral that we had that was specific for COVID was remdesivir, and that received EUA approval in early May of last year. Convalescent plasma followed soon after. There are also some in green. You'll see some of the immune modulator therapies, but really everything was for inpatients. And it really wasn't until, and Dr. Band already shared this earlier, it wasn't until the monoclonal antibodies got EUA authorization in early November that we actually had a treatment modality that could be used by outpatient providers and really try to prevent people from being hospitalized. And this was really a game changer, because we actually had the monoclonals about a month before we even had vaccine. And next slide. I also want to share that in development, the monoclonals, even though now they're only approved for use in mild, moderate patients who are at high risk for admission, as Dr. Bander shared, there are others that are being studied for use in pre and post-exposure prophylaxis. So this could be, for example, for folks that have not been vaccinated for whatever reason, or it could be an outbreak situation where people are exposed and they're at high risk for complications. Or it could also be used for people who are immunosuppressed and they can't mount an appropriate immune response after vaccination that maybe giving this passive immunity pre-exposure could be useful. So these are not yet approved, but they are being studied, so just stay tuned. Next slide. Now, this team that I was on, it's the therapeutics team, and since November, we've shipped almost 1 million treatment courses of the different monoclonal antibody therapies to about 6,000 unique locations, and about half of what has been shipped has been utilized and administered into patients' arms. Next slide. Now, Dr. Bander talked about this earlier, but I just want to highlight again, and this is a busy slide, but with the variants, there is a concern that some variants the monoclonals may not be effective against some of them. And so CDC is doing more sequencing of specific viruses, and they're reporting that on this public website, their CDC variant proportions data tracker. So I wanted to share that link with you. And based on the data that they receive, they are testing some of the very more common variants against susceptibility to the different monoclonals that have received EUAs. And there have been some recent changes with the combination therapy from Lilly, the bamlanivimab and etesevimab, where the proportion of some of these circulating strains, particularly P1, which has some reduced susceptibility for bamlanivimab, etesevimab, we've made recommendations in certain states not to use that combination and to use the Regeneron instead. And this is all changing. And so I'll tell you a little bit more about how you can keep up with our recommendations about which monoclonals to use in your state. Next slide. Well, so the rest of my presentation, I'm going to focus on 2 things. One is I just want to highlight some of the great work that the team that I was privileged to be part of on my deployment have been doing to really try to improve allocation, distribution, and administration of these therapies. And then on the second half of the presentation, I'll talk about some very specific resources that I've cherry picked that I think would be very useful for you. So next slide. So originally when the first monoclonals were approved, and the first one was bamlanivimab on November 9th, the way that you could get these monoclonal antibodies was only through state and territorial health departments. This was the same model that was used with remdesivir. And so the way it would work is that the federal government will look at the case data for COVID for the whole country. They proportionally divide it by each state or jurisdiction, give the state jurisdiction whatever proportion that was for how much of the therapy was available. And then each state health department would then decide which hospital, in the case of remdesivir, would receive the product. Each state made that decision without federal input. That worked well for remdesivir because there were only inpatients that needed that therapy. But with the monoclonals, there are so many other places outside of hospitals and large health systems that could use this therapy. And working through the states, when there was already so many cases, as you can remember back in November, it was very overwhelming for a lot of state health departments to really know which outpatient facilities in their states were ready to infuse these products. And so we developed this program called SPEED. It stands for the Special Projects for Equitable and Efficient Distribution. And the idea was that we were going to do direct federal allocation, essentially bypassing the state health departments for priority populations. And this was long-term care, federally qualified health centers, dialysis, and corrections. And many of these, as you know, serving underserved communities like Black and Brown populations and others. And so this program was the first time that we had done this direct federal allocation. It worked well. We were getting product during this peak period of cases. So we're very proud of this effort. And then that, then later led to as we got more supply of the monoclonals, it actually then where the healthcare facilities that had infusion capability, large health systems or outpatient facilities, anyone who had that capability could just directly order it from the supplier and didn't need to go through the state. So it's gotten a lot simpler over time to get access to these monoclonals. Next slide. Now, another recent change that was highlighted by Dr. Bander, but I want to highlight again here because it's such a game changer, is that the eligibility criteria really has been greatly expanded. So there are many more people that are now eligible for this as patients. And we need to make sure that providers are aware of this recent change. And so Dr. Bander mentioned overweight. Pregnancy was also added as a new criteria. And the initial criteria were very rigid. There were very specific conditions, very specific age and weight cutoffs. And there wasn't any language that allowed providers to use clinical judgment in determining if there were other people that were outside of those parameters, yet they felt they were high risk and would benefit. So now there's additional language, as Dr. Bander referenced, where it encourages providers to consider other factors. The authorization is not limited to conditions specifically listed. They can go beyond that, including factors like race and ethnicity. And they really encourage all providers to look at the benefit risk for each individual patient. So it really just provides that flexibility for providers, is what they were asking for. Next slide. Another thing that we heard from facilities and providers was that the reimbursement that was being provided was insufficient. And it was actually a disincentive for really providers to really trying to figure out how to get this into patients' arms, because it is a challenge in a lot of places to stand up these new infusion centers. And so the CMS, after much discussions, was mostly done by others on my team, particularly Dr. Meredith Chuck, who's the lead of the Allocation Distribution Administration team, Dr. John Redd, who was the previous lead. They had serial discussions with CMS over both administrations. And so now, just as of earlier this month, on May 6th, CMS increased the rates of reimbursement. Now remember, the drug is purchased by the government, so there's no cost to healthcare facilities for the drug itself, but the cost of administrating the therapy, now it's $450 in most healthcare settings. And then in home infusion, where there's additional costs with one-on-one nursing and travel costs, et cetera, the administration reimbursement can be as high as $750. Next slide. Another thing that this administration and that we've been really focused on as a team is equity. And so we have a $150 million investment that was announced in March from the Biden administration. The goal is really to come up with additional strategies and outreach to high-risk communities. And this is still pretty early. I talked to some of the folks that were working on it. Unfortunately, I don't have anything right now to share with you, but in some of these communities that have been prioritized, where there are folks working on the ground, there's a lot of collaboration with community-based organizations, like some of the ones that Dr. Bander mentioned, really trying to use trusted messengers to get both providers and patients and the general public aware of these therapies. So hopefully there'll be some good best practices and tools that come out from these efforts. Next slide. Okay, so then now, as I said, I'm going to talk about some resources, and this will be duplicated a little bit by the next speaker, Brian Nyquist from NICA, but there's just so many information out there. We really want to make sure that you have access to and are aware of them. Next slide. So the first thing I want to mention is really more for folks that are interested in maybe doing the infusions yourself. I understand that there's a mixed audience for NHMA. So we put on with Project ECHO at University of New Mexico an outpatient therapeutics mini-series. It ran from December through February, March, and there are 11 archived sessions, which you can see on this link here. And this includes a lot of great peer case presenters. Dr. Bander presented twice. We also have a lot of content experts. These are really helpful, particularly when there is scant evidence. And really you want to have those community stories about the challenges of how they figured out the logistics of how to get through things. We also have the resource library that has sample order sets, protocols. That's really helpful because this is one place you can find that if you're thinking about creating an order set. This is where you can look at it. And then there are 3 sessions that I think are really critical for the Latinx communities that if you want to, these are the ones that you can follow up on. Next slide. Now, I also want to mention here with home infusion, because of the reimbursement rates that were increased, Dr. Brian Nyquist will talk about how to find a facility that's doing infusion, but the National Home Infusion Association has a website including infusion resources for physicians, where if you have a patient who could benefit from home infusion of the monoclonal, you can contact this site and try to find a home infusion provider in your area. Next slide. Now, the Combat COVID site is an HHS website, which also has a lot of information. A lot of it's on recruiting patients for clinical trials, but there's a section of it that's specifically on monoclonal antibody education. And so there's quite a few fact sheets for both infusion providers and referring physicians. For example, here's one in the middle talking with patients about monoclonal antibodies. These are very useful resources. I want to make sure you're aware of them. Next slide. And then if you want to stay up to date, because again, with the variants, with new therapies that are coming out, ASPR is actually have these weekly calls that you can sign up for on Wednesdays. And then they also have office hours twice a week where you can ask questions in a more laid back setting. Next slide. And then finally, I just want to highlight particularly, this is useful for anyone, providers as well as patients in the public. If you want to help increase awareness about these tools, there are some shareable graphics that you can go to this link and then you can share on your social media. And I think that's my last slide, and I will hand it off to the next speaker, Brian.
Yes, thank you so much, Dr. Wong, and thanks for doing your own introduction. You just stepped in there when I went mute, so thanks a lot. I won't belabor the point, but I want people to know that Captain Dr. Wong has been a partner for NHMA and so many of our initiatives through the Office of Minority Health, and we welcome you again as a partner. So thank you so much. I want to end by introducing Brian Nyquist. Brian is a dedicated advocate for access to care, and he's been at this for about 20 years. He's the president and CEO of the National Infusion Center Association and executive director of the Infusion Access Foundation. Through NICA and IAF, Mr. Nyquist advocates for patient access to provide administered medication across complex chronic disease communities. Mr. Nyquist is committed to helping the nation's sickest and most vulnerable citizens access the health care they desperately need to optimize health outcomes and maximize quality of life. Before joining NICA, Brian Nyquist served as the policy analyst for the Texas House Committee on Public Health. Brian received his bachelor's degree in human biology from the University of Texas and his master's in public health from Texas A&M Health Science Center, the School of Public Health. I welcome Brian. You have the floor.
Thank you, Dr. Flores.
You're more than welcome.
Good evening, everyone. Thank you for taking the time to attend the session. As Dr. Flores covered, I'm Brian Nyquist. Pleasure opportunity to speak with y'all. Do a little quick background on NICA. NICA is a nonprofit trade association that represents the nation's non-hospital, community-based infusion centers. The goal behind our purpose is to ensure that the nation's sickest and most vulnerable citizens requiring provider-administered medications can access the right medication at the right time in a safe and cost-effective setting. A couple of quick disclaimers here. NICA does not own, operate, manage, or otherwise have financial stake in any infusion operations, and I have not been paid to give this presentation. The opinions expressed in my presentation are my own and do not necessarily represent the opinions or positions of NHMA. Next slide, thank you. So, accessing COVID-19 monoclonal antibodies, which I abbreviate as CMABs, for high-risk patients is not as simple as just writing a prescription that you're all used to. These medications are available under emergency use authorization, so there are explicit criteria for eligibility. To prescribe these products, eligibility must first be verified and documented before referring patients. As the pandemic response evolved, the EU criteria have expanded, so it's important to keep an eye on the latest EUA updates to ensure that you are prescribing as widely as permitted. So once you have documented, verified and documented eligibility, the script to chair journey may begin. So today I'll be outlining some of the factors that influence a patient's script to chair journey in accessing therapeutic biologic products like these COVID monoclonal antibodies. We'll cover resources to help optimize the patient experience, different education points within the patient encounter, how to identify an administration site, as well as how to navigate patient scheduling and broader navigation through the delivery channel. And I'll end by touching on some additional challenges to consider. One of the main differences between therapeutic biological products and conventional medications is how they are prescribed or ordered. Before we dig into resources, I'll speak to the order set and referral best practices. The prescribing and referral flow for provider-administered medications, like, again, intravenous monoclonal antibodies, are very different than conventional oral medications. Instead of a typical pharmacy benefit drug prescription, these medications require an order set containing additional information to document medical necessity. You can find a sample order set for the CMABs available under EUA in NICA's online resource center. And I will share a link to that resource in a bit. However, before your office begins ordering these therapies and referring patients, a best practice is to understand the access footprint in your community, to understand the patient presentation requirements and referral process as well. Do they have a preferred order set template that you need to use? Do they require a scheduled appointment, or do they accept walk-ins? Do they want patients to present to a dedicated entrance? Do they require test results? Do they require a specific kind of test? And then finally, how will they communicate back to your office when your patient has received treatment? A lack of diligence here from your office will contribute to delays in treatment, or worst case, no treatment at all. Now let's talk about some of the resources that can support access to these therapies. Next slide, please. So as we've covered thus far, there is a wealth of resources available online. Many are conveniently organized across 3 sites: Combat COVID, which Dr. Wong spoke to, NICA's Resource Center, and COVID Frontline. Please note that this is not a comprehensive list, but may serve as a starting point in discovering the resources that may help you maximize efficiency along the patient's script to chair journey. And while the URL for our resource center may not be very portable, the resource center may be accessed indirectly from our homepage, infusioncenter.org, via a scrolling banner or under the resources drop-down menu. Next slide, please. In the process of building the playbooks for each of these CMAB assets available under EUA, we also built supplemental materials for prescribers, infusion providers, and patients based on lessons that we've learned from past biologic drug launches. And we've identified these materials are critical to support uptake and integration of these complex provider-administered therapeutics. Materials like multilingual resources, referral checklists, how to prepare for a CMAB infusion, order sets for both the Lilly and Regeneron combination therapies, and discharge instructions can all be found in our CMAB Resource Center. Additionally, general education videos and decks to help with general monoclonal antibody education, like our Biologics 101 slide deck, can be found in our education hub on our website. For those of you that are considering operationalizing your own CMAB administration site, we also co-hosted a webinar with HHS's ASPR team, or the CMAB administration team under ASPR, to help current and prospective infusion providers understand the barriers to CMAB integration and which pilot models have been successful. And you may access a free recording of that webinar also in our resource center. Next slide, please. So now that you have the resources to verify and document eligibility and to begin prescribing these therapies for your high-risk patients, let's walk through some of the critical education points to cover during the patient encounter. One of the primary factors contributing to primary non-adherence or failure to start a prescribed medication in the case of biologics like monoclonal antibodies is insufficient education at the point of prescription. In the context of CMABs, it is very important that patients understand what monoclonal antibodies are, how they're different from conventional drugs, why these patients are eligible for these products, how they work, how they differ from not only other conventional medications, but also how they differ from vaccine, what the coverage landscape looks like and patient out-of-pocket cost liability, what to expect when receiving the therapy, where to get the therapy, and then finally the risks and benefits associated with receiving these CMAB therapies. Forgetting to advise a patient to dress in layers with warm clothing because putting 65-degree saline into the bloodstream will lower the core body temperature is one of the most common complaints that we hear from patients. And it's been a very common obstacle and hurdle and factor really that's been contributing to a suboptimal patient experience as it relates to CMABs. Not being prepared because they weren't primed on what to expect has contributed to many very uncomfortable patient experiences and distrust in their prescriber and in many cases the broader healthcare system. Many Latino patients have been carrying a deep-seated distrust in the US healthcare system for generations. We do not want or need to exacerbate factors that are driving inequities in healthcare, health outcomes, and access to care, specifically products like monoclonal antibodies. People are generally averse to the unfamiliar. People are familiar with vaccine and they're unfamiliar with CMABs. The prophylactic vaccine paradigm in infectious disease management was compounded by the misconception that emergency use authorization equates to insufficient evidence, which Dr. Bander contradicted in his presentation. As such, the public perception has been that the COVID-19 monoclonal antibodies were a temporary, risky, and investigational stopgap until sufficient vaccine was available to get us well on our way to herd immunity. Now the vaccine is widely available, the perception is that these therapies are no longer relevant in the context of pandemic response and disease burden management. As Dr. Bander explained, it takes time following infection for the body to produce antibodies against the SARS-CoV-2 virus. CMABs jumpstart the immune system to reduce the viral load and consequently reduce symptom burden. It's critical for patients to understand that while vaccines help prevent infections, monoclonal antibodies help them get much better, quicker if they become infected. In an analogy or metaphor that I've been using, is much like how painting a car will prevent it from rusting, but does not fix any rust already on the car. Alternatively, a rust remover will get rid of rust to a certain point, but does not help protect from future rust. And if you have too much rust, a rust remover won't help. Using these two products together, however, you can reduce the damage caused by existing rust if you address the rust quickly enough, and then you can paint the car to prevent future rust. There is one common theme among patients that never make it to the infusion chair. They did not understand the relationship between vaccines and CMABs, and that if infected, monoclonal antibodies would have given their immune system what it needs to immediately fight the virus to reduce the severity of infection. The majority of these patients presented after symptom onset associated with early stage 2 or stage 2A of disease, as symptoms are lessening or patients are asymptomatic. The patient declines therapy at that point as they're feeling better, but days later, high-risk patients return after the cytokine storm associated with stage 3 of disease, bringing on a second wave of symptoms and increased severity, only to find that they are now outside of that 10-day eligibility window. If patients leave their encounter with you better informed, we may be able to keep more patients out of the hospital. Next slide, please. So how do you start identifying the access footprint within your community? Well, you can use one of the two locator utilities that are publicly available. The U.S. Department of Health and Human Services offers a locator tool at protect-public.hhs.gov. NICA offers a dedicated CMAB locator tool at covid.infusioncenter.org. NICA and HHS are exploring ways that we can consolidate these two tools into a single comprehensive tool. And to help prescribers and patients find CMAB administration sites, NICA has mobilized our core locator technology to create a secure, dedicated user interface with infinite scalability. The goal in this effort was to support broad accessibility of CMAB through access point transparency. Next slide, please. The first time you access our CMAB locator, you will see a pop-up dialog and subsequently 3 questions. Once you answer these 3 questions, you will not be asked them again unless you clear your browser cache or you use a different device. If you allow the browser to use your location, the locator will auto-list CMAB administration sites within a default 30-mile search radius of where you are. And we've included the ability to adjust that search radius if needed based on market. If users do not allow their browser to use their location, the locator will auto-display the Austin market. But we've built in searchability so that users can search for access points in other markets. As an extension of our current workflow, NICA and our partners at Lilly and Regeneron have called every single site in our CMAB administration site locator that was shipped a CMAB to verify that they were an active site as opposed to redistributing product to a secondary site, and that the information that we had was appropriate and accurate for consumers. Sites denoted as verified in our locator were confirmed as being active administration sites, and we also confirmed that the information that we had was accurate at the time of verification. As the delivery channel has evolved, so did the access footprint and contact information. To help us capture these market dynamics and convey the best information possible to patients and prescribers, we gave sites the ability to manage their own data. And additionally, we built a crowdsourced feedback form so the general public could help us identify information that needs to be updated. Sites that are denoted as unclaimed in the locator have not requested the ability to manage their profile data. Next slide, please. So if you click on a location, either in the map display on the right side of your screen or on the search results on the left side, you'll open that site's profile. Within that location's profile, you'll find many data fields. What I've included on this slide is an example of what good looks like. This location leveraged the site level data management capabilities in the various data fields we've included in this profile template to convey pertinent information and instructions to prescribers and patients specific to CMAB presentation and workflow. Combined with functionality like click to call or click to get directions, we've provided very powerful capabilities in efficiently connecting patients with care settings. Sites that have leveraged these capabilities have been much more easily identifiable and consequently have furnished a significantly higher volume of CMAB therapeutics than other administration sites. Next slide, please. So by now you've verified eligibility, you've identified a site, you've completed the order set, and you've initiated the referral process, but you're not quite done. This is a critical junction in the script to chair journey where too many patients fall through the cracks and get lost, even with the arsenal of manufacturer-sponsored patient support services that were unfortunately not available for products under EUA. Who's responsible for scheduling the patient's appointment? Is it going to be you? Is it going to be the patient? Will your staff help the patient schedule an appointment, or will the patient be responsible for scheduling the appointment after they leave that patient encounter? Based on historic patient behavior in the presence of a narrow eligibility window, patients that leave your office without an appointment are far less likely to make it to the point of care. So again, going back to a similar question, who will coordinate that patient's navigation from script to chair? How can your staff prevent loss of these patients? Even if the patient is scheduled, there are significant obstacles that drive attrition in the absence of adequate support with patient navigation. Communication with the patient is the most important piece here to help them navigate to and through the point of care. How will you know which patients receive the therapy? Did you anticipate communication barriers for patients with limited English proficiency? These are very important questions to work through with your referral network in your particular community. You need to have not only a strong line of communication with your patients, but also with your referring sites. So you know what that communication stream looks like. So you're notified every time a referred patient actually gets treated. Even after doing everything within your staff's power, there are still opportunities to lose the patient once they get to the point of care. Any one of many factors that impact the patient experience can result in a lack of treatment. It is just as important to have a strong line of communication with your referral sites as it is with your patients to make sure you know who received therapy so you can follow up with them. And you can follow up, more importantly, with those that have not received therapy and help pull them through the delivery channel. For patients that may face communication barriers, those with limited English proficiency, for example, you need to ensure that the referral site has the resources needed to help those patients navigate communication barriers. If they do not have those resources available, feel free to reach out to organizations like NICA. We can help connect those sites with some of the vendors that we work with to provide LEP resources. Next slide, please. However, even with all of this due diligence, there are still a lot of challenges to consider. Until we drive a paradigm shift in how we manage high-risk communicable infectious diseases, the public perception will remain focused on prophylactic vaccine as the saving grace. We have to do better at educating patients on the role that monoclonal antibodies do and will continue to play as reactive treatment options alongside prophylactic vaccine. We must continue to get better at communicating test results to PCPs. Although we've started to get better, there's still a significant communication breakdown resulting in patients exceeding that 10-day eligibility window before their PCP is aware that they've even tested positive. We must also continue to get better at connecting patients without an established PCP with a prescriber as soon as they are notified of a positive test result. We must also be sensitive of infusion shortage areas and infusion deserts and focus capacity expansion efforts on those areas that are seeing increasing incident rates. We also must continue to get better at reducing patient attrition along the script to chair journey. And we must consider communication barriers for patients with limited English proficiency. It has been an odyssey to get where we are, but we still have an incredibly long way to go. However, the availability of CMABs alongside vaccine, we are seeing the light at the end of what has been a very long tunnel. The more efficiently we're able to identify eligible patients and get them through the script to chair journey, the more effectively we'll be able to manage the burden of COVID-19 by minimizing COVID-19 related hospitalizations and incidents of ventilator use. However, unless we, again, drive this paradigm shift in how we manage disease outbreaks, CMABs and MABs in general, developed as reactive treatments for subsequent outbreaks, will continue to be underutilized. That's all I have today. Thank you for the opportunity to speak on this important topic, and I look forward to an interactive Q&A discussion. Dr. Flores, back to you.
Yes, thank you. Thank you very much. I think that for those who can put their questions into the Q&A, please do so. If you can, just put it into the chat because I haven't been able to open it up myself. I really want to move on to the questions. This has been a challenge for many people, and I want to start off with a question. Some of us have been involved with patients that really are within that 10-day window, and we're very anxious to get people into treatment. But the barriers to getting them, even with in states like New York and cities like New York that are very well supported, I would imagine are much, much greater in places where there's a private practitioner trying to get a patient in and has the clock ticking. What do you all, I want to pose this to all three of you. What do you all think might be the best approach for us going forward?
I think that for us on the clinical end, I think it's knowing when you do the test, you already know who you're going to refer. So if someone's coming in, they're symptomatic and you're testing them, your clock has already started before the test result comes in. So if you already know they meet criteria or they're high risk, and if they're positive, that's when you should start that journey. That really eliminates, and Brian gave a great talk about the nuts and bolts, but the earlier you start, the better. So I think that the key change of minds that we'd like to have here is that, when you order the COVID swab or test, whether it's antigen or PCR, you already begin that referral process in your head. And if it's positive, that patient knows they're going to get a call to go get the monoclonals if you're at risk.
Yeah, I don't think we can really emphasize that enough, Dr. Bander. The quicker you start this process, the better. The less attrition we're going to see, the more profound the impact of these products are going to make in disease burden minimization. But I think we need to focus also on the patient population that are going to present for testing independent of a PCP order for that testing. We need to do better at educating these patients at the point of testing that they are eligible. They meet eligibility criteria. They may need to talk to their doctor if they test positive about this particular option. This is particularly important, again, for those patients that don't have an established primary care position.
Yeah, and I would just add, I think both of you covered, awareness is really, I think, the biggest barrier for both provider side and on the patient side for these monoclonal antibodies. And I'll just provide an anecdote from one of the ECHO sessions that I mentioned earlier from St. John's, which is a fairly qualified health center, about 60% Latino population. They were the first fairly qualified health center to receive monoclonal antibodies through our SPEED program. And Jim Mangia, and I encourage you guys to watch his session, one of the things that he shared was that, there was a high refusal rate amongst the patients when they offer this monoclonal, because many patients were hearing about this for the very first time at the time when it was being offered to them, and they didn't understand it. They didn't have enough information. And so they developed actually, culturally appropriate and specific awareness materials, flyers, brochures, ways to educate the patient, because they wanted to reduce that barrier. But as Dr. Bander said, there's been so much emphasis on vaccine That's what people know. That's what they read in the media. Monoclonal gets a very small slice of that.
Yeah.
I think we really need sessions like this. We need providers to do peer-to-peer learning, sharing these materials that we've, links and et cetera, that we've all shared today, both on the provider side and on the patient side.
So thank you. There is a question actually in the Q&A regarding the uninsured and how this is covered for the uninsured. And I would add to that a question as to what are the supports for smaller practices and FQHCs just to get the navigation, not actually to have a site, but get the patient enrolled and transition to the site for infusion. So it's two parts. I want to start with Dr. Wong, if I can.
Well, I shared a link in the chat or in the Q&A that is the HRSA program for the uninsured. And so what that provides is a way for providers to take care of uninsured patients. There's not insurance you can bill to get that administration fee that was recently raised, from $310 to now $450, as high as $750 at home infusion. They can use the HRSA program to get that administration cost back. So we don't want, the uninsured to be a barrier for treatment. So it needs to get the same kind of, level the playing field in terms of reimbursement there. So I want to make sure people are aware of that. Second, I also think that with access, this was your second question, I really want to mention again the home infusion therapy, because that was not something that was very easy to do early in the outbreak because the reimbursement was so low.
Yeah.
A lot of home infusion providers would lose money giving this therapy. But now that the reimbursement has more than doubled from $310 to $750 for home infusion, I think it's a much more viable option. So I really want people to be aware of that. And because of the cases that are decreasing now, because of vaccination, we're in a different stage of the pandemic. Now there's fewer cases. So what we're hearing is some of these places that had opened up as infusion centers, some of them may be closing. And so there may be fewer options there. So again, think about home infusion as a possibility as well.
Okay, I'm going to move on again in the Q&A, but just not to leave this topic, how does immigration status affect your ability to get this therapy? I think this is again for Dr. Wong.
Yeah, it shouldn't matter. I think, that's not anything that we ask. That's not anything we ask providers to ask. It would still fall under, I think, an uninsured kind of situation in which there's a way for you to get reimbursed for the administration cost.
Okay, thank you. I have a question in the Q&A, and the question is basically about the current variants. And I know you spent some time, Dr. Bander, talking about the current variants and the CMAP administration addressing this. So maybe you can refresh that a little bit. People want to know how effective they are with the current variants.
I think that, David also said that government, CDC also has these websites, and it's changing because we don't know. I gave a little bit of the basics, but I think each state by state, there are specifics what to use. And I think what the important message is that there are more monoclonals in the pipeline. And so that even if more variants build up or the P1 becomes dominant, we have a lot more of these in the pipeline. So we may see, just like we talked about vaccine boosters coming out, there may be other monoclonals that come out. But as of right now, effectiveness, state by state, based on which variant is predominant, they may recommend the Lilly product or the casirivimab and Imdivimab product versus the Lilly product.
Okay.
And I would
ready for more questions? Yes.
Just to piggyback on that, so I think that's great. The point that there are additional monoclonals in the pipeline that are being studied, that's very important. But then if folks want to stay abreast, because CDC, FDA, the ASPR team is constantly reviewing these data on a daily basis. Updates will be provided through those weekly stakeholder calls, and actually information will get pushed to you. So if you get on that listserv, when there is a change in the variant status for a given state based on the threshold, you'll get pushed an email. I got an email right before this call. There are 5 additional states because they exceeded the threshold for P1 that they're recommending using the Regeneron product versus the Lilly product. That just came out today. So again, it's just a dynamic situation, but people are studying it.
Do we want to make sure that we put the email link in the chat regarding the ASPR?
Yeah, it's one of my slides.
Very good.
On it, but you can put that in the chat as well.
Thank you. Dr.
And then
Bander, I'm sorry, Brian, you were going to say something. I'm sorry.
Yeah, just one last point to add there. The reason that we're seeing a shift towards combination therapies, specifically in the case of abandonment of bamlanivimab monotherapy for the BAM and EDI combination therapy, is to address variants in mutation-induced vaccine evasiveness. In the case of the Regeneron product, for example, they developed an initial combination therapy asset that didn't have overlapping epitopes to account for mutations or the rise of variants, et cetera. That appears to be sort of the medication technology strategy. And then again, there are additional assets in pipeline, unknown what that's gonna look like. Sorry, I'm trying not to share more than I should. There are more options coming. Expect more options. These products aren't going away. There's a clear shift in this direction because they are so effective at reducing hospitalizations and some of the complications associated with high-risk infections.
Okay, I have another question, and the question is, what would you say to people from certain states, Massachusetts being one of them, where it's apparently being recommended not to use the Bamalav and SD combo? So I will give that out to any panelist that wants to take it.
Because I can start with this one.
Brian, yeah.
So there's a lot of research going into the variants that are sort of popping up in different markets, specifically based on the proportion of new cases that they're represented by those particular variants. And there's a lot of science going into which of these monoclonal antibody assets are most effective against a particular variant. And so Captain Wong referenced some materials, site where folks can go to learn more about sort of what those latest recommendations are. But for the most part, the system is, Captain Wong, correct me if I'm wrong here, but the system in and of itself is sort of shifting to put the right asset where we need it based on the variant footprint within that particular market.
I think that's right. And I would also just say from like a practical standpoint for that question, like the Regeneron in Massachusetts, which is one of the states where the threshold of P1 has exceeded 10%. Yeah. Not recommending to use the Lilly BAM-EDI combo, but the Regeneron combo is still effective for that variant. And so I know that there's efforts to get more of that Regeneron product to Massachusetts. There may be some opportunities where there can be sharing across state lines for states that are nearby that are not as affected. There may be other ways. Hopefully you can find the Regeneron product for the patient in front of you, which you want to treat as soon as you can, that you'll have access to that Regeneron product. Because, the whole goal of making this recommendation is that we want the monoclonal to be effective. And if we feel like there's a certain proportion of a strain that's not going to be as effective against a certain product, we really want to shift towards, the one that is more effective. And so it's just a bit of a logistics challenge, but I know my ASPR team that I'm no longer part of because I'm rolled off of that team, they're working very hard on this issue to support not just Massachusetts, but the other states that are in a similar situation.
Yeah, so I think the takeaway here is prescribers don't really need to worry about variants in which product to prescribe and all of that. Active administration sites are continuing to order product. They're being shipped the appropriate products based on the variant footprint in that particular market. So you should continue using the locator utilities, continue finding those access points, stay in constant communication with your referral sites to make sure they are still active and they're still ordering product. If we do have new CMAB assets that become available under EUA that may be covered or distributed in a different way, the rest of us working in the background will pivot and adapt accordingly so that prescribers and the general public need to just focus on identifying, verifying, prescribing, sending, getting those patients treated and verifying that they got treatment.
So thank you very much, Mr. Nyquist. I'm going to pivot to Dr. Bander because I'd like to hear a little bit more about your experience in the community, with the communities, in particular in New York, with the FQHCs and getting people really to address the multiple barriers that are there for providers and for patients to get this therapy. So maybe if you can share a little bit of what your successes have been.
Yeah, I think that the alignment of it's a trust, as we said, brought up a few times, about the trust that the patients have in this therapy. And there was as we saw in the beginning, there's so much confusion about, lots of the therapeutics that were thrown out there, from hydroxychloroquine to steroids to, remdesivir, and looking at that. So people kind of didn't know who to trust, so they would trust their doctors. And so I think what helped us with the FQHC communities, and specifically where the community we first had a lot of early impact on, in the Jewish community, there was a community leaders were struggling to try to help their community, and they looked at the options and they learned that this was an effective tool. So that education that took place in that community really brought the trust brought up by the community leaders, allowed the patient to say, wait a minute, what should I do? Community saying, hey, this is an effective treatment. That really empowered the doctors and the patients to want to get the treatment. So I think that worked. And the FQHC environment in general is when it's your doctor administering it to you and you're not being sent somewhere else. And it's sort of, what worked in FQHCs was also that patients were there, they got an antigen test, and it was positive, they would just send it to the next room and give it. There was none of this kind of stuff that Brian's trying to deal with, where you have to get out. But unfortunately, can't always work. But that's a good model, as David said, where you can just now do a home infusion. So there's no barrier. It's like, we'll show up to your house and give you the infusion, and your doctor tells you you should get it. So those are the two main lessons I think that I would
Lessons
get.
learned. That's very good. I wanted to go over also, someone asked a question related to allergies. Is there a specific allergies one has to be careful about? And I will also add immediate reactions. So allergies and immediate reactions to the infusion. Who would like to take it? Maybe Brian, would you like to take that one?
Yeah, I'm happy to jump in here. So
thank you.
Severe allergies is not necessarily a contraindication for CMABs. There are a lot of immune compromised patients that are receiving other monoclonal antibodies outside the context of COVID-19. For example, for severe allergy-induced asthma. And those patients don't necessarily have a hypersensitivity reaction every time they receive those infusion therapies. There are protocols in place to manage patients that are displaying signs of hypersensitivity. There are ways that we can manage those patients to still get them a therapy in the safest way possible. It's going to take a little bit longer, but there is very, very well-established practice and protocol around there. NICA has established nationally recognized industry standards as it relates to reaction management and basic everything outpatient infusion related. So not necessarily contraindicated.
I would also ask, the question has also been asked about pregnancy. Is this a contraindication?
So it's actually interesting.
Dr. Bender, yeah.
In the beginning, it wasn't excluded. It was a discussion with your doctor. And we actually found that pregnant women were extremely high risk. And it's also the same group of people that is often very careful what they put in their body. But pregnant women, actually, we've had a lot of experience with it. I've had good success with pregnant women, and they are a high risk group. So I really actually do encourage it as well. Same thing now, I think, what we talk about with vaccines, that you're actually passing on immunity to the babies as well. So I do think pregnant women are high risk, and it should be discussed with their doctor.
Right.
Okay.
I just want to highlight again, so with the new expanded EUA criteria, pregnancy is listed, which it hadn't previously been. And our experience from the Fed side is that pregnant women have done very well with the monoclonals. And so I think it definitely should be encouraged. I also want to put in a plug for the ECHO series again. We have a session on managing allergic reactions.
Yes.
Speaker from Harvard Medical School talk about it. One of the things that I remember from that session is with monoclonals, you get more side effects and adverse reactions depending on the source of the antibody. So if it's a murine source, a mouse source of the monoclonal, you're going to have a lot more adverse reactions. But the monoclonals for COVID are all human derived. And so the side effect profile is much smaller. So just as good information in that session.
So I'm going to stay in the same neighborhood of reactions and contraindications. So we're going to go into people that are immunosuppressed, severely immunosuppressed, and also post-kidney transplant patients. Are they eligible or good candidates for this therapy? And lupus, when I had lupus, of course. Dr. Bender?
Yeah, I mean, they definitely are candidates for this. It's the, one interesting thing that, there's a lot of post hoc data coming out. We looked at ours. I mean, the higher risk patients are, the more they are to progress. Now, just like the vaccines, it doesn't necessarily eliminate disease, but definitely decreases severity. But, we've had some of these patients even get monoclonals who have liver transplants or immunocompromised. They can still get sick, but definitely recommend that you give it because we don't have anything else.
Yeah, and of course, the question will also be extended to people that are receiving chemotherapy.
Yeah,
That-
yes,
would
the
that be-
higher,
that would-
the higher the risk,
Yeah.
the more benefit they'll get.
Yeah, that's correct. I also wanted to talk about and this I'm going to give to both Mr. Nyquist and to Dr. Wong. All three of you can take it, but I'm going to kind of direct it to you. A lot of the challenge is getting people to trust and getting people that are eligible to move quickly and receiving the therapy. So a lot of people that may be eligible are not going to be willing or trusting to get this therapy right away. So what are we doing in terms of public facing education and engagement, just like we do with vaccines? What are we doing in that case to make people aware, so when they are in this situation, they can move quickly and trust that this will be effective therapy? It's a long question, but it really has to do with engagement and the ability to get people in quickly and trust the process. So maybe we'll start with, who shall we start with? Anybody that wants to take it first, and I know it's for all three of you.
I can start. I think so. One thing I highlighted in my presentation was the $150 million that the U.S. government has put for underserved communities. Some of that work has been working with trusted messengers, just like people are doing with vaccine. You have to look at your faith-based communities, your community health workers, your promotores, your public health nurses. Those are folks that people might listen to in the community, particularly if they have a long-standing relationship with them. And so I know, for example, in some of those communities, they put up pop-up infusion centers on church property. I would like to see more work done actually with community health workers to help, for example, with the navigation, because the locator tool that Brian talked about is very helpful, but sometimes people need additional assistance beyond that site. And so I would love to see if we can do more work with that. I think the patient navigation part is challenging, depending on the specific community, and could use more improvement. And then the outreach, as I said earlier, with the providers, and really working on those referral pathways, making them as smooth as possible. That's something that I think we also need to think about.
Yes, I also saw something from Dr. Bander that he has breaking news. So
I didn't have
no?
Milton Louis broke the news.
Okay.
One of the, again, we spoke to Abcellera and some other things that are in the works, as Brian mentioned. There's lots of them. So now the FDA just granted a different one of these monoclonals, which is in a different region of the spike protein. So again, as we said, there'll be more options on the table. 5 minutes later, more options on the table.
This is rapidly evolving. I still want to stay on the issue. I want to stay on the issue of engagement. I like that, Dr. Wong, that you let us know that we're using the same methods that we're using for vaccine engagement, we use for monoclonal. So is there a place for us to pretty much educate on a continuum and engage on a continuum, and letting people know that there are different options depending on their situation, whether it be to be vaccinated, of course, but if they've gotten sick, to make sure that we get that out there, because this, unfortunately, the messaging to many communities is still, if you are sick, stay home. So how are we going to change that narrative a little bit and maybe include it in our vaccine work? This is going to be to everybody. We're going to start, of course, with Captain Wong.
Again, our message, again, awareness, awareness, awareness. I mean, monoclonals just does not have the same level of awareness as vaccine. And so I think the more we can get this education out and the knowledge, that's going to be so helpful. With the message about staying home when you're sick, that's definitely a challenge. And so we've worked with CDC, for example, on their website to have mention of monoclonals as an option if you're sick. I would like it to be more prominent, on that website. It's there. You kind of have to dig a little bit, but like we have to think about all the places where people access information. So Brian talked about at the time of testing. So I know my colleagues are working with LabCorp and Quest and some of the large testing companies, you know, when there is a positive test and someone meets criteria, that there's a message on there, a link or something that they are aware to talk to their physician about this. All these kind of little steps along that patient journey, as Brian discussed, we need to really, you know, laser focus on all the things that we can do to enhance uptake, knowledge, buy-in on the patient and provider side along that entire journey.
Yep. I can add a point here. So, and I think it goes back to a point that was just made. We are so reliant on trusted sources to champion this messaging across targeted cohorts. And you all are that trusted point of contact for the patients that you serve. Your patients are looking to you for guidance, and specifically and in particular, your confidence in prescribing these products. And I think what we can all do is do our part. Every conversation that's related to COVID, specifically COVID response, COVID treatment, vaccine, or anything else, we need to do our part to interject the fact that CMABs are the most effective treatment for high-risk patients that become infected. Vaccine's great. Everybody needs to get vaccinated. But if you're high risk and you are infected, irrespective of whether you've been vaccinated or you've gone through the whole series or you started the series or you didn't start the series, that is your best option at reducing the burden of disease. We need to just tell everybody that we come in contact with, every relevant conversation. It's what we need to do. And then in addition to all the work that the ASPR team is doing and the HHS is doing through the KPMG partnership, we can all do our part by just being a champion of that message. Sorry, go ahead, Dr. Flores.
No, it's not my show. It's your show. I'm learning. Dr. Bander, I've been on those calls, those ASPR calls. That's how I first got started. I really feel that as a physician and provider, we're really not getting all the information that we can get in the same way we're getting information around vaccination. And I do a lot of these talks, and I always add at the very end, what happens if you get sick? And I throw in the monoclonals, but that's not really officially part of what we're supposed to be doing, especially on the state level. So I would definitely like that support, Dr. Wong, from you and from others to interject that and to make sure that that is in all our presentations and all our engagement work. I wanna begin to close because I think we've answered all our questions, plus many of the ones that I generated. And I want to end with statements from the three of you. So I'd like to start with Dr. Bander and see if you can give us a closing statement.
Yeah, I think that this, one of the things from monoclonal teaches the power of science, and looking at what trials bring, and that when we took us from the time the pandemic came out till now to develop two really good treatments, the vaccines, obviously, which are preventing it, and the monoclonals, which treat it. So we've done a very good job, and I think it's good hope for all of us that we as a nation are able to tackle these kind of problems with science and government and industry working together.
Mr. Nyquist, you go next.
I'm sorry, I didn't hear the question. I was trying to type out a response to one of the questions we had.
Okay, I just wanted to give you an opportunity to close your statements if you have something else to say.
Thank you. I think just the main takeaway here is this is such an important tool in our toolbox to get us through this pandemic. The public perception is so hyper-focused on vaccine, that vaccine is the solution that's going to get us through this. But CMABs serve a very important role alongside vaccine in really helping us get through the pandemic. Right? Vaccine is going to help you prevent infection, but in the event that you do get infected and you're high risk, you're going to need a CMAB to reduce that disease burden and avoid hospitalization.
Correct. And even if you get CMAB at, I think it's a 90-day window, you are eligible for vaccination?
10 days.
10 days?
10 days after a positive test.
10 days
Right.
after pass. No,
Symptom onset.
no, I'm talking after treatment with the CMAP. I
Oh,
think
I'm
it's
sorry.
Yeah, it's 3 months, 90 days, I believe.
Yes, I'm sorry. I thought you were talking about
No.
the eligibility window to receive the CMAP.
No, if you
Oh,
get
yeah.
treated, you still should be vaccinated, but it's a 90-day window afterwards. Dr. Captain Wong, you get the last say.
Well, I'd like to end with an offer.
Yes.
During my time with the deployment team, I was so impressed with all of the dozens of associations like NICA and hearing the stories of folks like Dr. Bander working with the community-based organizations to really beat the pavement, get out the vote for people to be aware of this.
Yep.
It was so impressive what the associations and CBOs are doing, on the local level. So I really want to applaud everyone. And so for the associations and the organizations like NMHA and others that maybe are on the call or hear this later, if you would really like to work with us at HHS and ASPR to help work with you to get better education for both your patients and your providers, I'm happy to help. Even though I'm not on the team, I may need to lateral you over to the team that's there, but it's going to be a team that's going to be there, until this is no longer needed. So they're not going away, and we're happy to help.
I would be very happy to help, and I will share that with everyone, including Dr. Rios, who's not on tonight, but definitely is listening. So I want to thank you all very much, very much. I want to thank you, the panelists, the participants, for shedding light on something that is really extremely important and doesn't get enough attention. And I'm going to hand it over to Vito so he can close us out. Thank you, Vito.
That's it, Dr. Flores. Thank you everyone for your time tonight. Thank you to our panelists. Thank you for joining. Here are some ways to contact NHMA and our foundation to get involved with our Vaccinate for All campaign. So thank you all again for your time, and we look forward to working with you all again in the future. Have a wonderful night and stay safe.
Stay safe and thank you all. Good night.